Hello everyone. Today we are going to discuss another spectrum of stroke, that is intracerebral hemorrhage, which is not very common, but if presented in a patient has a very devastating complications and has a bad mortality as well as morbidity. So what is intracerebral hemorrhage? It is basically bleeding into the brain parenchyma, and this bleeding can occur and extend into the ventricles as we see here, as well as inside the subarachnoid space like we see here. It can be secondary to the rupture of either the small penetrating arteries, either due to your hypertension or vascular anomalies, or it can be even spontaneous intracerebral hemorrhage or secondary to some trauma like the traumatic intracerebral hemorrhage. So it is classified into two types, primary ICH and secondary ICH. Primary ICH is most commonly due to the hypertension or cerebral amyloid angiopathy and is more predominantly seen in as a part of lobar or non-lobar hemorrhages, which can be either infratentorial or supratentorial. Whereas secondary ICH, which we saw, it can be secondary to some trauma which a patient has undergone, or because of the anticoagulants patient is on, like patients on prosthetic valve endocarditis, or patient with a history of DVT or pulmonary embolisms, or with APLA syndromes, we see that they are always on some of the other anticoagulants to keep their thrombotic status low. So for those patients, it can present as a secondary ICH, or it can be because of some vascular malformations like AV aneurysms, perimal aneurysms, saccular aneurysms, or it can be as a presentation of cerebral venous thrombosis, or secondary to a drug abuse like usage of cocaine, which causes cocaine-induced vasoconstriction and rupture of the blood vessels. So location, as we all know, that mostly intracerebral hemorrhage is commonly seen in basal ganglia and internal capsule, more common in thalamus, and then to some extent around 11% we have it in the cerebral hemispheres, and in cerebellum it is around 5 to 10%, and very minimal it is in the brainstem, that is brainstem intracerebral hemorrhage is a little less common, around 5%. So what are the risk factors for formation of intracerebral hemorrhage? So it is more or less the same as we saw for stroke. It is usually a comorbidities like hypertension, diabetes, poorly controlled your diabetic status, or hyperlipidemias, or alcohol abuse, smoking, some illicit drug abuse and other things, CKD and other things. So here also the risk factors are more or less the same. We, for our easy understanding purpose, a comprehension purpose, we divide it as modifiable risk factors and non-modifiable risk factors. Among the modifiable risk factors, you know, it is hypertension, previous CVA, alcohol and illicit drug abuses, usage of oral anticoagulants or antiplatelets, which is very common, or usage of COX-2 inhibitors or SSRIs. The non-modifiable risk factors would be advanced age, male sex, cerebral amyloid angiopathies, or Asian ethnicity, cerebral microbleeds, aneurysmal formation or familial aneurysmal complications, or CKDs. So how does a patient with ICH present? The presenting symptoms are usually headache, very bad headache. Patient presents with a very severe headache. In a little extended spectra of subarachnoid hemorrhage, we call it as a thunderclap headache. That is the worst headache patient has undergone. Otherwise, in an ICH, the first presentation is definitely headache, vomiting. Sometimes patient can even present as primarily as seizures, then with a focal neurological deficit or low GCS and obviously high blood pressure.